So this is ocular trauma. Some of you, I guess the third years, this would be a similar lecture to what you heard a couple of years ago, but it's hard to remember. So I'll ask the question again. Can anyone identify the structure or what is happening in the nasal conjunctiva here? So this is a guy who came in from the Middle East for a consult while I was in Miami, to see if anything could be done to restore his vision in this guy after trauma. Anybody have a guess what's going on there?
Auto extraction, cataract extraction.
Yeah, exactly. The coolest picture I had ever taken.
You know, I had one. I had a woman sent in from Lundgren's office with that.
It's a beautiful picture, isn't
Yeah.
it?
It's pretty cool.
Okay. I didn't do anything for him. Anyway, okay. We'll get it started. All right, so.
Did
So
you
this,
take out the lens?
no, I left it there. It was intact. It
This
was,
is your thing.
he was comfortable.
Was it a blind eye?
It was a blind eye.
Oh, okay. My patient's got vision.
Yeah?
Yeah, my patient auto extracted a lens. I just put a lens in Wednesday.
Where was it? Where was it?
It was
The
under the
Taj?
Taj, yeah.
Yeah, very cool. Yeah, he was not NLP, but he would have had to do a lot of surgeries and ultimately we decided to leave him alone. He was
Well, that's
comfortable
good.
and
That's good. I was just thinking the lens, you know, it's a privileged immune site, but if it's intact.
it was
should be okay.
intact.
Yeah.
I was intact, presumably. There's not a lot of inflammation around it, so anyway. Okay, so this is chapter 15, posterior manifestations of trauma. So there are several classifications that they go through in the book. Blunt trauma, and I don't know if some of these make that much difference, like the penetrating versus perforating, but they do want you to know. So blunt trauma is where there's no break in the eye wall. Can someone tell me the difference between penetrating and perforating trauma? They want you to know that.
Penetrating one hole.
Exactly.
Perforating two.
Exactly, comes out the other way. And that could be referring to a particular type of structure as well. Like if you were talking about a penetrating versus perforating lens trauma, you could use those words too. Intraocular foreign bodies can be penetrating and perforating as well. So this ocular trauma score is not something that I ever have used to counsel a patient in terms of their percentage of seeing these numbers, because I don't think it's that helpful to the patient themselves, other than if you look at the left-hand side and you look at the vision, globe rupture, and endophthalmitis, you know that those patients are going to do worse. And I do sometimes tell a patient, the initial presenting vision is probably the most important thing to know for the final vision. And that kind of helps them understand a little bit how serious the problem is, because oftentimes if a patient comes in NLP after trauma, they do not know that they won't regain their vision. They don't have any grasp of that. So, all right. So the history is important to take the mechanism of what happened, although never trust that, because a lot of them are not consistent with the history that they give you for various reasons, but also it's just happens very fast and they don't exactly know what happened. The timing is maybe important, especially because of NPO or because of infection status. The NPO status is important in some places. Where I trained, you had to be NPO to take them, and ruptured globes were not done immediately. Now where I take call, for instance, they'll cancel everything else and a ruptured globe will go immediately regardless of NPO status. What'd you say? How do they do it here? Do they wait? They wait until they're NPO for 8 hours?
No, we don't seem to get priority.
You just get bumped. Yeah, okay, got it. Understood. All right, I got that. I did that too. Okay, other surgeries are very important to ask about.
Where do you get priority?
They care. They'll
And
bump everything and put you in. Even without me asking, actually. They'll just
why
wait.
do they do that?
That's a good question, but I've never wanted to ask.
Okay, well, I was just thinking it might help the argument here.
Yeah, they call it like a level 1 case. Ruptured globe is a level 1 case, and I don't think they understand like, oh, this person is no light perception. So, it maybe is not that urgent. So anyway, there was a lady who had a golf ball injury a couple of weeks ago, and she had a ruptured globe, and she was NLP question mark. And they bumped a bunch of people, and I went into the surgeon's lounge, and they all said, "You're the person who bumped us all." I was like, "Oh
That's
gosh,
good.
I didn't know."
Good for you, enjoy it.
Yeah, it was great. I went home before bedtime, and they didn't. Anyway, but that doesn't usually happen, so I've paid my dues in other times. The phaco, PK, LASIK, these are questions you might not ask and I don't know if this was really in the book, but it's really important to me because phaco wounds open. Oftentimes you'll see uvea out, iris outside a phaco wound. And that's going to be easier to close. And you wouldn't counsel the patient exactly the same as if it were a traumatic rupture rather than just you burped a phaco wound, LASIK, be very careful with these because you have to be you have to know where that they have a flap and what to do about it, right? PK, oftentimes these will open around the PK wounds. Where I trained, cornea would want to close their dehisced PK wounds versus, so somebody different who wanted to close the globe. And so I would, it would just be a whole different team. And strabismus, if you ever are taking down muscles, this is important to just know it's gonna be a lot harder to take down the muscle if they've had strabismus surgery. And although maybe it doesn't make that much difference, you might want to measure how far back you took it off to put it back on, etc. And also to know if, we don't know if this patient has had 3 of their muscles taken down and before, and now you're going to take down the 4th one, and that is probably not a good idea. So you should just ask the questions, and they might not be able to give you the history, so you just have to do the best you can. At work, this is important for workman's comp cases. I know that it might not be something you think about, but it might make a major difference to the patient in terms of their bill and everything like that. Documentation is very important. I once had a patient who was uninsured, and my front desk called their employer and said, like, should we call OSHA, or are you going to pay for this lady's surgery? Barb in our front desk, and they paid. So they weren't going to pay, but anyway, that was really nice of her to make that work. So anyway, so if you can't adequately perform the exam and you think that there's a ruptured globe, you should probably just stop and just take them to the OR. That's just going to be the safest way to examine them. Look at their other injuries and vitals, look for an APD and document it. The vision, especially in children, is you really shouldn't trust it. Take it as a piece of information, but don't trust it. Especially, in patients who are kind of delirious in the trauma bay, they're sometimes intoxicated. If you're confident that there's no globe rupture in a trauma situation, take the pressure. It can be important to know if we think that there's a orbital compartment syndrome or something like that. There are other things that you need to know so you should have the pressure. Confrontational visual fields, EOMs, these are just part of your regular exam. I think sometimes it's easy to get distracted by the, missing ear and skip steps, but just go back and make sure that you have everything documented, not only for documentation's sake, but it might come in handy. So face and lids, document that as well. If the clinical scenario, you're looking for a foreign body, I've found a BB in the fornix that other people thought was intraorbital, and we're going to go and do an orbital exploration when you just flip the lid and there the BB was. So just, I wouldn't do that if there's a ruptured globe. You can do it in surgery, but give a good thorough exam of everything. And always examine the other eye. If you don't do it in the trauma bay or wherever you're seeing the patient to start with, I always get a consent for examination under anesthesia of the other eye. and I document it like a regular exam. Other than the vision, of course. Let's see, so the corneal wounds can be small and self-sealing, so, you know, a good exam with a slit lamp will be helpful. Please document and make sure of hyphema, foreign body, or hypopia and AC. That's really going to be very vital for your management. So yeah, just go systematically through all of the anterior segment. Cataracts are important to note. You oftentimes need to think about where the lens is in a trauma, because if you don't see it, it doesn't mean that it's, you know, they could have an IOL that's just hard to see, or it could be dislocated or absent, you know, in the conj, for instance. Yeah, just the same as what I was saying. So, a lot of times when there's eye trauma, I noticed that residents will have a hard time knowing when to dilate and when they shouldn't dilate. And really what you're trying to avoid when you're dilating an eye that's had trauma is to unplug a wound that the iris is plugging. So if you see an anterior wound that the iris would be plugging, then don't dilate, because you don't want to disturb a wound that might be stable at the moment. But otherwise, I don't find any reason to not dilate unless, that's very few patients. If anyone has any other thoughts about that. Okay, vitreous hemorrhage, optic nerve compression, and avulsion, which is rare. I think I've only seen one avulsion. Tears and detachments, choroidal rupture and Comosho or Berlin's edema is very common. So you're going to see that a lot. Where I trained, I would see a lot of Berlin's or Comosho, and we would use that to say maybe hold off on orbital fracture repair. We would say, like, you know, low risk of fracture repair for if there's nothing wrong with the globe. And then if there were Comosho, we would say maybe there's a moderate risk, and they might put it off, you know, for another time if it was indicated. And I don't know if that's truly that important, but something to think about at least. So, if there's suspicion for globe rupture, or any, really even a low suspicion, get a CT of the orbits. You can find things that may be important. I always told them to do thin cuts of the orbits and look at all the views that they give you. MRIs are contraindicated in patients with metallic foreign bodies. B-scan is really reserved for patients who you don't think have ruptured globes, or if they had like maybe a pinpoint, but otherwise the teaching will be never to B-scan patients. And I would not do it if I were a resident unless, you know, you discuss this with your attending physician and there were a compelling reason to do it, and you really didn't think that there was any active opening in the globe. So these are just some pictures, I think, of ruptured globes versus foreign bodies and things like that. Okay, some exams are very confusing in trauma, so always ask for help. This patient was a monocular patient who was basically auto-enucleated in a car accident. We couldn't ever find any evidence of where the globe went. And so it was very confusing, as nobody knew what they were looking at, you know? And so they got the CT, and then you just come and examine the patient. There's no eye there, you know? So it's hard to counsel the patient. They really want to know what's going on. But just take your time. So this is the resident telling the patient to look up and down and left and right. And
nothing there.
There's nothing
It's
there.
so weird. I mean, how does that, without ripping your face off?
I can't explain it, but
Yeah,
it
we've
was
done
the
it.
worst
Yeah.
conversation, one of the worst conversations I've ever had
It's
to have.
not easy to nucleate an eye.
Yep, I agree.
Yeah.
Yeah, I don't know
To
how.
not disturb the lids. It's almost like that, like on Kill Bill.
I don't have an answer.
And pneumothermin.
But the patient was monocular, or the other eye had amblyopia, so she didn't see from that eye. It was a horrible conversation. Okay, so blunt trauma. So choroidal rupture, you probably will see this at some point in residency. This is tears in Brooks membrane. Basically, usually they look just like this, usually this white kind of curved line. And and they go concentric to the disc. And somehow they always like to hit the macula, and not be further away. But these patients should be watched, for CNVs, and if it goes to the macula, their vision is oftentimes quite poor. And there's no treatment for it yet, maybe one day.
There was actually a cool study where someone did the distance from the fovea. Your risk of a CNVM was proportionate to the proximity of the fovea.
Of course.
It's kind of an interesting thing, so I thought that's kind of interesting.
Interesting
Yeah.
and sad.
Yeah.
So macular holes, traumatic macular holes are not necessarily treated like spontaneous macular holes. They have a higher rate of closure in my experience, but maybe the vision isn't as good in the end, but I usually wait at least 6 weeks of following the patient before we even talk about it. I've never seen scleropateria, or at least probably I have seen it, but there was so much hemorrhage in front of it that I did not know that it was there, and probably just saw a scar later. And oftentimes if there's so much hemorrhage, I don't take the patients to surgery if the B scan looks like they're attached. So maybe we're just waiting for a long time until these are healed. But these are for high speed projectile injuries to the orbit. And there are large areas of choroidal and retinal rupture and necrosis. They combine with extensive subretinal and retinal hemorrhage, and then they get a lot of scar.
And they don't detach amazingly.
The scars are good, right?
Yeah.
In that way.
Yeah.
Yeah, I never saw this in residency or fellowship, and only when I came here to Tampa General did I have the pleasure of being introduced to scleropateria. Roger Gestalter introduced it to
Oh,
me.
very nice.
Yeah.
Scleral rupture, this is for more surgical planning. It often occurs at the limbus, the muscle insertions, or as I told you earlier, old surgical wounds. This is phaco wounds. If you see a superior concentric to the cornea wound, think of old extra cap wounds and things like that, and PK wounds. So we talked about that. So perforating injuries we discussed have entry and exit wounds, and there can be a lot of fibrous proliferation that goes through between the two. Wounds usually close by fibrosis in a week, which is why a lot of times if they're not closed surgically, you wait about 10 days before you go in and do anything so that they can close. Posterior wounds sometimes are left open to close by themselves for that reason. And if you're trying to get really posterior, you have to kind of torque the eye so much that you can cause more damage than just leaving it alone if
You really introduced.
yeah, you really kind of UVO will come out, retina will come out, and better to have just maybe left it alone.
Just do the
Anterior thing. Yeah. I have different opinions over time as to whether or not taking down the muscles is helpful in the long term or not. Opposite of helpful, harmful in the long term. I've done it many times both ways, and I can't tell the difference of sometimes when I take down a muscle, like, should I have done that, or should I just left the muscle to let it close, you know? So
The neatest thing I saw with the guy who went into plastics, this is 40 years ago. I asked him to hook the muscle, and he hooked it, and I said, well, take out the hook. He said, why? I said, because I can see it behind the pupil.
Yes, absolutely. That's also a reason that when we're doing scleral depression, that, we make sure that there's no old wound that's unstable. I was worried about that I always make sure I have to do my scleral depression very obviously before I make a tunnel or something like that. I just remind myself 10 times. Okay. So penetrating injuries. So this is my ruptured globe protocol. I'm sure that every hospital does it differently. NPO, bed rest, don't send them home under almost any circumstance. I had to do that once during a hurricane, but past that, no. Box shield without any pressure. You might see like they come in with tape, from I don't know, whatever EMS might have brought them. So make sure it's not touching them. Always review the CTs themselves, show a HIPAA compliant video to your attending doctor or your senior if you're, a first year, for instance. Look for irregular globe contour, intraocular air, foreign body hyperlucency, et cetera. Those are important. I think that's just another video of a globe rupture. Oh yeah, so you can see that was like an irregular scleral contour right there, nasal. I used to give antibiotic, and this is probably helpful for you guys, not that helpful for me if they're bumping every other case for me and we're just taking them straight over. I used to give antibiotics, fortified Vanco and topramycin every hour, until the patient went to surgery, and that might have been up to 24 hours, many hours. I use 1 dose of PO Levaquin, and in surgery, I actually give either intravitreal or intracameral, depending on the type of injury, antibiotics. I use Vanco and ceftazidime. And so the pharmacy just makes them. That's one of the first things I do when I see a ruptured globe is I call the pharmacy and tell them to start on that. And then I call them about every 45 minutes until it's ready, because it takes many phone calls. So I think that I always tell the patient the goals of surgery are to attempt to close the globe and prevent infection. And so I tell them and I point out that I'm not talking about their vision yet, because that's so far down the road to figure out that, that those are the 2 goals of surgery. And we already talked about that the presenting vision is the best predictor of the future vision. And I do tell them if they know, oftentimes they know how bad it is, especially if they're older, they seem to have much better insight into, this sort of problem. And like the young people don't have any idea that something could be permanently wrong with them. And so some of them will ask the question. I'm very honest with them. And I also tell them the good news is if the vision is poor, some people are really concerned with their cosmesis, and that there are lots of good options, and, we're going to get them to those options as best we can. I do sometimes counsel patients that there might be more than one surgery, depending on, you just have to feel out their situation. Because if you just leave it very open-ended in the beginning that we're going to try to close the globe and prevent infection, they don't necessarily think that there won't be more surgeries, but you can point it out. And for intraocular foreign bodies, I kind of used to tell people that metal is a poison, and this is one situation where sometimes the presenting vision does not correlate well with the final vision because of PVR and detachments, and so I tell them that on the IOFBs, especially like a small intraocular foreign body that hits the nasal retina and doesn't cause a big vitreous hemorrhage. They can actually see really well to start with, and not necessarily long term. And it's not really an option to leave the metal in the eye, except for if they're not light perception, if they're not no light perception, maybe light perception. If you feel like they're going to be no light perception, you could talk about not leaving it if you're going to just let the globe kind of go, or in other extreme circumstances. Most patients do general. I think that probably every patient with a ruptured globe at this hospital goes under general. Is that right? Okay. And so I think that is great. I trained in a place where they did ruptured globe under a local. You have to be extremely good at your retrobulbar block to not
That's insane.
extrude. Yeah, I didn't have any choice, and in this situation, and actually they went very, very well, which is surprising to me in retrospect. I would not do that again, but
You would be crucified.
I was taught.
well, this is all like almost every
It's Miami.
one in Miami.
Yeah.
Yeah, that's how
Yeah,
they.
there's publications.
There are a lot. I'll show you. Yeah.
There's publications.
And this was all with the eye anesthesiologist. That's all they did. And so this is one of the Geyers actually was the head of anesthesia where we did this. And
Harry Flynn, yeah.
yeah, so it
Gutsy guy.
yeah, it is absolutely possible, but if you could avoid doing that, I would. I
So
didn't,
it was
I never enjoyed it.
retrobulbar, it wasn't subconj or?
No, it was retrobulbar.
I always felt.
And they would, I mean, they knew what they were doing. They did a good
You
job of
probably do
it.
like a 1 cc or 2 cc.
Yeah,
You probably
say
just
how
fit it in the
much,
right
couldn't be
spot.
that much
You
volume.
can't-
You know,
You're probably-
I don't even, I wasn't all usually there because they would do them
So
before.
you guys didn't do it? You
No.
had an anesthesia.
The eye
that did
anesthesiologist,
eye
and that's,
anesthesia, wow.
that's the only thing that they did all day is, I mean, not specifically retrobulbar blocks
Right,
on,
right, right.
but-
Yeah, you have to know where. you
but
are.
that you have to be really, really good at it. And I would never do that anymore because I already don't like giving retrobulbar blocks, honestly. And so, I don't enjoy doing it. So I don't like to not know where my needle, you know, I put a needle somewhere that I
Yeah.
don't see. It bothers me. So, anyway, the timing is as soon as possible, definitely with less than 24 hours, unless there is a contraindication, which there oftentimes will be, like a neurosurgical problem or the patient's in the ICU and not stable to go to surgery, in which case it's the eye versus the brain and the rest of the body, and you just have to give them antibiotics and carry on. And then sometimes you have to coordinate one surgery with ENT, neurosurgery, things like that. Like this guy, who has a wrench through his eye into his brain, which was a very cool CT, and his lid looks great in the end. The eyeball, not so much, but there's the wrench in the brain. So basically we were taking out the wrench. We were taking out the wrench, but we needed neurosurgery there while we're taking out the wrench because it's in his brain. And then they had a craniotomy and they're doing their part while we're operating kind of like to the side, closing his globe and his lid. See, his lid looks great. He didn't, his globe was closed, but all right, so here are the open globe classifications, in zones 1, 2, and 3. And really, the further you go back, the worse it is. But even number ones can cause horrible visual outcomes. Intraocular foreign bodies, inert sterile foreign bodies. This is like glass. I've seen them be left and do okay. But watch closely for endophthalmitis. Zinc and aluminum, minimal inflammation. I think this is kind of funny because you don't know, how are you gonna know what something's made out of? But in the book, at least copper and iron are very bad.
You know, the story on intraocular lenses, from World War II. was-
Yes, that they were left.
Do you guys know that story? That's why IOS developed it, from the windshields.
Exactly, because they went in and they were well tolerated, no inflammation. Okay, maybe we'll make lenses out of these.
Kind of cool.
It was a plexiglass or something like, yeah, I think it was
Yeah,
PMMA.
whatever the
Yeah.
windshield of the airplanes were. So calcosis is basically deposits of copper in decimase, and they cause all these listed, which you should remember, you should memorize those lists of problems that can be caused by that. And it can look like endophthalmitis, which you just treat it like endophthalmitis because you don't know, at that point if it's calcosis or endophthalmitis. But lower percentages can cause a more chronic appearance. So again, siderosis with iris sphincter and dilator deposition. You can have an abnormal ERG. I'd be surprised, I guess, if you get that far, but without knowing. But anyway, intraocular foreign bodies, we talked about CT with thin cuts. So make sure you ask for thin cuts because sometimes they have multiple problems like sinus, and you're getting a CT of the sinus because their maxillary sinus has a fracture and you don't do thin cuts of the orbits, and then you can miss small orbital foreign bodies. Sometimes you don't have to take out the intraorbital foreign bodies, depending on where they are, and I would have your oculoplastics friends help you with that. And then, it's important to gain as much information as you can about where an intraocular foreign body is before you go into surgery, because sometimes they're much harder to find than you think that they are. They can be in the angle and there's a hyphema. They can be kind of in the ciliary body, and then they're very hard to find, especially in a phakic patient. So, and then sometimes they can just be intrascleral, but it's very difficult to know if it's penetrated or not, or if it's just kind of like embedded. So sit and look at your CT before you go into a case like this and really try to get as much information as you can. And then, of course, trying to know what type of intraocular foreign body is helpful, but sometimes not possible. Always look at the CT yourself. There have been so many times where the radiology read is not correct, and it's up to you. You're at the end of the line, so no one's going to say, "Oh, well, you're not responsible for this because the CT was wrong." Was read wrong. So there can be a lot of intraocular foreign bodies. So look at all parts, look at everywhere and try to understand where everything is. Remember the mechanism, if it's kind of like a spray of intraocular foreign bodies or not. And then, because if you're going in to try to remove one and there are a bunch of them, then you have to know that. And also, what's the most important? Is there one in the brain? Let's deal with that first, maybe. And so gunshot wounds, the bullets oftentimes will kind of explode, and then you get a lot of fragments. And so you might need to do that, and then have oculoplastics, have ENT, have all these different types of people. When do you not operate? NLP eyes, I've not taken out intraocular foreign bodies in any NLP eyes. But they can't have MRIs in the future, so. When you go down the road, these patients have a lot of complications, and you should know them as residents, because the patients might have questions, and you also need to counsel them, because even though they're with you in your service, and say you're working with a glaucoma attending that helped you close the globe, they're gonna end up oftentimes with other specialties, and setting them up to understand this is extremely helpful. You say, "Oh, remember how we discussed that you might end up having a consultation with this other type of doctor?" And this is very helpful for them. In the beginning, they'll say, "Oh yeah, I remember that," and they kind of get less anxious about it. So, endophthalmitis, although when I do the intraocular or intravitreal or intracameral antibiotics, I have not had a case of endophthalmitis after a ruptured globe. But do you guys do that routinely here, or you just close the globe without antibiotics?
Depends on the injury. If
Okay.
it's like from vegetation, like a tree branch.
Yeah.
we Usually do it.
And you do antifungals too at that time? Yeah. Yeah. Be careful when you're putting those in at the end of the case, because usually they're 0.1. Sometimes if you're just using it for prophylaxis, I would put 0.05 in, a half dose. But be really careful, because if you put in Vanco, Ceftaz, Bori at the end of the case, and you've just closed your ruptured DHPK wound, as I've done this before, and you'll just pop 3 of the sutures again, because the pressure goes up so much. So make sure that your eye is really soft when you put them in, or you do an AC tap, depending on where it is, but don't just put in like 0.3 into a globe that you just closed.
But the other thing is, the reason they may not do it is, you may have a choroidal.
Yes, of course.
Or a retina sitting there, you may be getting a subretinal. So if you
Absolutely.
can't see, it's
That's why
probably,
I put in sometimes intracameral, especially because in those situations, the lens is oftentimes not there
yeah, so
anymore.
it's all one.
And so it's your unicameral. And so if you ever have a unicameral eye, I see no real downside to putting the antibiotics in and just putting them in it with a 27 gauge anterior chamber cannula in the AC, because you should have a clear space at the end of your surgery. At least, you should be able to see your cannula very easily.
But the other thing is, you have ultrasound.
Yeah.
There, because if, the other thing is the volume of the eye may be different. So if you have a big hemorrhagic choroidal.
Yeah.
Which presumably you would know, but you might not.
No, you
Yeah.
might not.
You're gonna have a different volume,
You're right. So if you use
Yeah.
0.05, I've generally not had any problem with 0.05 in terms, because even in patients who are filled with silicone oils who have very little vitreous space, that's what I use.
Yeah.
I use a half dose. So
Yeah.
like I said, with a 0.05, I've never had an endophthalmitis. and have done hundreds of.
It's, when you calculate out the concentration, it's an overwhelming
Yeah,
dose. You
it's-
can't come anywhere close to that with systemics.
Yeah. But I have seen post-globe endophthalmitis in patients who haven't gotten any antibiotics, so I do it every time. Okay, so let's see. Endophthalmitis we talked about, retinal detachment and PVR are the most common that you'll have to talk about. Corneal scar and needing a PK is a very understandable thing to a lot of the patients, but because that's oftentimes where the injury occurred. And so they understand scar, you know. Secondary IOL, if you get to that point, that's wonderful. They're doing great. If you have, you know, glaucoma is something that patients don't understand, you know, why that would happen. So you kind of have to tell them, like, we're going to be checking you for all of these things for the next year or something like that. Strabismus, traumatic optic neuropathy, hypotene-entisis, just things you need to counsel them. And I wouldn't necessarily counsel them on the first day about this. It's too much information. We talked about endophthalmitis. Be serious is 25% of post-traumatic endophthalmitis per the book. Like I said, I've never had to do a tap and inject and to see what the result was, thankfully. So if you cannot close the globe or the patient is NLP, you can talk to them about enucleation. I never do this on the first day. I always close the globe. But if you knew that there was some explosion of, you know, and there was no globe to close, you know, if there was not tissue to close, then of course, I suppose that would be the only option, right? But or unless you're doing some kind of graft, but I think at that point, I would just send them for enucleation. There's 1 in 500 risk with penetrating injury. Like we said, primary evisceration should only be performed if the globe cannot be repaired. Enucleation within 14 days may reduce the risk of sympathetic ophthalmia. And so evisceration may have a better cosmetic outcome, but more risk of sympathetic ophthalmia. So I let the oculoplastics doctors deal with that. It oftentimes presents within 3 to 12 months of trauma with decreased vision, loss of accommodation, photophobia, and pain. And then you can have panuveitis, Dalen-Fuchs nodules, exudative detachments, optic nerve edema, and uveal basically thickening, or I guess it depends on where in the UV you're talking about, what you would call it.
I have done primary evisceration, and it is wonderful.
Yeah.
It is one of the simplest operations in the world. And, you know, if you have a, 22 millimeter laceration, the contents of the eye are out there.
Yeah.
And the patient's not intoxicated in NLP.
Yeah.
You're saving the patient
Yeah.
an enormous amount of pain by not
Just
go
I
to
I
get
can
it
see
done.
that. I can see that. I think it really depends on where you trained.
And
Really,
you get to
you
go
know.
home at a decent hour.
That's true. That's true. I think how I was trained is that the patients oftentimes have a really hard time processing the loss of their globe, and to have it gone on the same day as the trauma is a lot for them. And so they like to know that you've tried, you know, but I have done it in situations where it's just so abundantly clear that to everyone, including the patient, that like there's no hope for this, then I've sent them.
I have a quick question.
Yes.
Yeah, so we had a similar case rather recently, which is the patients that had like a major trauma. I think a car hit him or something, and all of his eye, the retina was all out of his eye already.
Yeah.
But the issue, and he's in the ICU and in a coma, unfortunately. But and we waited a few days to see what to do. But the issue was his other eye was NLP already, just from a prior injury. So our attending ended up having us do a primary enucleation. But I just wonder how how to kind of explain that, because the patient ended up waking up about a month and a half later. So
Yeah.
you know, I know it's a difficult situation, but like, how would you have handled it the same way? What would you recommend?
In general, if I thought that the globe was closable, this is just me, and Dr. Paven might do it totally differently. If I thought that I could close the globe, I just close the globe and that's it. There are a couple of good things about that and bad things about that. Good thing is sometimes even a blind eye looks better than having
Mhm,
a
mhm.
prosthesis in, because
yeah.
insurances don't always pay for the scleral shell, right? And that you might not have insurance, so you might be eviscerated and just have your conch covering your socket, but you can't get a prosthesis. And then that's very disfiguring because you just have a ptotic lid, and it's better. People, if you see someone with no arm versus a prosthetic arm, it's easier to say like, oh, the prosthetic arm, you're more comfortable with that. It's easier to look at someone who has a blind eye and not be as distracted as if they have no eye, it's just, so. I would think of a lot of things in that situation. You had a long time to think about it. I'd probably talk to their family members or friends if you could. And then I would, just to kind of get a sense of the patient.
I certainly agree with all that.
Yeah.
I mean, these were extreme, this was an extreme.
Extreme
I done
situation.
it
You
maybe
do what you
once,
can.
twice, that's it.
Yeah, you
In
just-
39 years.
exactly. So that shows you how often it really gets done. But, and there are some patients who, I did this professional baseball player once who I think probably I could have made a different decision and it might have been better. I wouldn't say that it was the wrong decision, but he knew that his globe was, his eye was gone. And we said we're gonna close it, but you might need a nucleation evisceration. He asked in that time, can't we just do that first? And we kind of said like, well, let's just see if we could close it, and then he needed a surgery a week later. So, but he was, well insured. I think he was okay with the whole, looking back on it, saying like, okay, we did our best, right? And so would he have regretted it later if we didn't? It's really hard to tell,
It's
And
hard
so-
because a lot of these patients are not really conscious or in their
No,
right mind.
you're
at
right.
the
No, yeah,
time,
yeah. So I think in that case, best to just close it
Yeah.
and say,
Mhm, mhm.
and then
That's
enucleate
what I've
later.
always
But
done.
insurance is a big issue. If patient is uninsured and you're positive that they're gonna need an enucleation, then you can think to yourself, we can either, usually from the emergency room in my training, you could do one of the two, but you can't do both, be an emergency, situation from the ER. So you really have to, at that point, maybe just talk to them a lot about, this is the reality that you don't have insurance, so we only get to do one of these surgeries. So anyway, and so it turns out that I end up almost never sending people for enucleation later. It just doesn't happen within 14 days. They can't process this at this point, and so they're not ready for another surgery.
If you look at that literature, and I did as a resident, it's terrible.
Yeah.
It's,
Okay,
and it's anecdotal.
the sympathetic one.
Yeah,
I thought that was retracted more recently. I think there's more recent stuff where people say that's not, I gotta look at the books, but I heard a year or two ago. someone
wouldn't
said, yeah,
surprise me,
That
because
whole
the
14-day thing.
the
is
old,
kind of
the old
intense.
literature is just terrible.
Yeah,
If by modern standards, it's
Yeah.
anecdotal.
Yeah, I think patients do much better if you give them time and they say like, I'd like to have no eye surgeries for a while,
Well, if you close the anterior wounds, the
Yeah.
incidence of sympathetic is really low.
Yeah. So, okay, avulsion of the disc. Maybe you see this, maybe you don't in your training, because usually there's hemorrhage everywhere, right? The disc has its large vessels in it. So to just see it avulsed is, I find very unlikely. But extreme rotation and forward displacement of the globes, penetrating orbital trauma, sudden increase in IOP, like a rupture of lamina fibrosa, which we see all the time, right? And there's a pit-like optic nerve depression, and you can see it on imaging. I mean, a CT would be how you would probably see this, maybe a B scan. And I guess that is it. So I skipped a few for the for the sake of time, because I think the first time I gave this lecture, it took like an hour and a half. I didn't know, there
That
were
was very good.
questions and, so anyway, I think that, a couple of things that are the most important for when you're closing ruptured globes is first, start by closing the limbus. That closing your limbus is absolutely the most important part of doing this. It has to be closed correctly. If you see patients who come back to you later with the limbus that's like 2 millimeters off, it's horrible. It's horrible. And you think like, oh, this doctor didn't know what they were doing. It's actually not true. It's very hard to find the limbus sometimes. And so close it where you think it's supposed to go, then just start putting sutures in, and you will know after a little while, okay, it's not exactly where it was supposed to be, and you just have to restart. And it's okay. You just take a few sutures out. You say, okay, the limbus is here, make it perfect. And then you start again. And I think that ruptured globe repair is a game of ever tightening sutures, where, you try to inflate the globe, but the globe is not inflated to how it's supposed to be. And so you are making too loose of sutures, thinking that your globe's going to be more inflated. And then as you gain more form to the eyeball, you notice that they're not the right tightness, and you have to go back and do it over and over and over. And so even a small laceration can sometimes take a really long time, because it has to be, sometimes the sutures will be a little off, and so just
It doesn't
close
take
it.
much.
Yeah.
It
Just-
What are
doesn't
your
take-
suture
and then you get a
choices?
leak.
Yeah, exactly. I closed the limbus with, I used to say that I closed it with a 9-0 nylon, but I have such a hard time rotating the suture sometimes that I end up closing it with a 10-0. And then I
You
spent,
put a 9-0 in first though,
Um,
and get it all set and then 10-0 with.
I usually just 10-0 it. I
Okay.
say that I do 9-0, but in my mind, but no, it's never, because I can never rotate it. And I think that closing the sclera with Vicryl to start with is really helpful, as just to like get the globe in place, and then add some permanent sutures on top of it, because
Are you 7-0 or 8-0?
so I usually use a 7-0, because you can get it really nice. It looks great, and then you kind of want some permanent sutures in there. So I just add them, but the globe is closed and the sclera is closed with Vicryl, and then I just put them
So
on
like
top.
every millimeter.
Yeah, and then I just like fill it in
Fixer,
between. Yeah,
not
it
Tons of.
usually, I used to do it with 9-0 nylon the whole way, but it would take so long, because it's so much faster to do it with Vicryl. So I just like close it with Vicryl.
You
then
don't run the micro, or do you?
I don't know.
So I have